So hello everybody. Thank you for the invitation. I'm sorry I couldn't make it in person, but the ever-changing travel rules meant that I had a small collision in my diary. So I'm Bernard Kainz. I lead a small international research group who's interested in intelligent algorithms for better healthcare. So in this brief talk, I will try to explain you why I think that algorithmic anomaly detection is extremely important but underrepresented in current clinical practice and research. My personal vision are really self-driving medical image acquisition and widespread but safe health screening. Unfortunately, for this vision, we cannot really rely on what's currently known as AI in healthcare. And let me explain briefly why I think this is the case. So why are we doing medical imaging? Well, in general, there are two reasons. Probably the most common one is that, well, some symptoms indicate that there's something wrong in your body. Often you'll be referred to imaging tests so that a group of medical doctors can really confirm or probably exclude a number of known or suspected conditions. You know, the key assumption in this case is that you're in bad health and that there's something wrong with you since you have symptoms, right? So conversely, the other big group of reasons for doing imaging are health screening tests, where the base assumption is actually you are in good health and that everything is fine with you. Examples you might be familiar with are mammography screening for breast cancer or fetal health screening during pregnancy, where you would assume that actually everything is fine, but just to check you're doing imaging here. So for us in computer science, the particular healthcare domain of radiology is a very welcoming playground. Radiologists are also very interested in adopting our techniques. Not at last, since Jeff Hinton said once, well, that we should stop training radiologists now. I think this has been this statement has been adjusted in the meantime slightly, but we are still probably some people are still implying that machines will soon replace radiologists. Now, in radiology, there are many machine-like tasks, like in the daily routine, like delineating organs or tumors or things like that. There is a lot of potential for automation here, which is welcomed automation, things that people don't really want to do. There is a significant interest in the medical community and in medical industries. Recently, for example, a couple of years ago, in the biggest conference for radiology, RSNA, one of the keynote speakers was a computer scientist, no radiology background. So this is how far we are really involved into radiology. So there's diagnostic data explodes. If we would continue to acquire data at this pace, then it wouldn't take very long until probably all of us would need to be expert radiologists to be able to read and interpret all of this data. And well, large amounts of data are not always a bad thing. Actually, that's what we want to do, what we want to have in machine learning. So there are large amounts of data available, both structured and unstructured data, and also recent initiatives like UK Biobank and other imaging initiatives that try to get a holistic picture of the population, of the inside of a population, right? Through asking volunteers, healthy volunteers, to do MR scans, full body MR scans, we get a really good picture of how healthy humans usually look like from the inside. There's also a large amount of potential layers. This is less structured, usually more unstructured in diagnostic reports or diagnosis or the patient information themselves. And there in radiology and medical image analysis, there are lots of synergies with recent breakthroughs in conventional computer vision. Now, what we do really increases in value the more we go towards the clinical practice. In the beginning, computer science probably was more concerned with how to acquire images and how to interpret sensor data and translate it into image data, and followed by image enhancement. How do we make these images better? How do we interpret these images, at least partly, by delineating certain areas, organs, bones, vessels, diseases, tumors, and so on automatically. And well, since the dawn of machine learning, we can do this very well, and can also go one step further and produce quantifiable biomarkers, something that's very relevant in medicine, where you would try to break down complex disease into small quantities. And then, well, yeah, I think by now we are going towards computer-aided imaging guidance, for example, in screening, where our algorithms start to have an impact and really help to make decisions at a consistent quality. And well, at some point, probably, I can give you a device, you image yourself, and with the help of a computer algorithm, you make a diagnosis yourself. So since machine learning came up, especially deep learning, there have always been the idea to use this to make machine learning useful for the daily practice. Now, for the first group of imaging tests I just showed you, we could make a very naive assumption and declare that machine learning and AI is basically the way to go. Most of you might be familiar with one of the base paradigms in modern machine learning. Basically, collect a lot of observations from each class that you want to discriminate and to classify, and then show these samples together with their labels to a machine learning algorithm. Right? That's probably something everybody's familiar with. Generate the data, do huge bottleneck, and then fit your model. Now, CNNs helped really to make this paradigm accessible for imaging and for computer vision, because CNNs can convert these images to something where we can fit models like these. But this approach is known since much longer for unstructured clinical data, like individual measurement values. So I could try to make a broken bone detector in this case and show a machine learning model a lot of images of broken and healthy bones. After a while, the system will be able to distinguish between these classes and produce me something like that. So I perform this model, and then I get well, if I make a naive assumption, an AI doctor, which can tell me for every image if it's healthy or diseased. Now, what's with this case? So this image here has no broken bones, but the patient isn't healthy either. Our naive model has no other chance than to put this patient into one of the two buckets it is familiar with. It's either images with broken bones or images with healthy bones. Since there are no features of broken bones in this image of Paget's disease, it's likely the model will actually categorize this patient as healthy, but that is obviously wrong. This patient is not really healthy. So human decision makers would not have this problem. They might miss signs of disease occasionally, but because of, well, some disease might have subtle appearance or maybe fatigue, or in general, sometimes things get missed. But if you think about it, we as humans would approach this problem probably completely different and in comparison to this AI doctor here. So I would argue we as humans do it slightly differently. I think the more common approach is when we look for problems in general, not only in medical imaging, that we would rather look for deviations from the norm, from a canonically mental model, instead of direct signs of potentially thousands of individual diseases. We might do the latter later, but initially I believe that we as humans rather look for oddities, strange patterns, really deviations from the norm. So what do I mean with a mental model, a normative model in our minds? So let's do a quick exercise. Just close your eyes and imagine a hot dog. Well, everybody of you will have some sort of image in their mind of how a hot dog looks like. With this model, you might agree that you would immediately be able to build a mental discriminator to distinguish anything, any other thing, from a hot dog. Now, this is what we want to build in machine learning. We have one normal class, thousands and thousands of images which are all normal. We don't need to label them as normal because we just know these are normal. And we want to discriminate them from anything else in the world, from other images, from whatever we know, but also most importantly from the same class of images, but with disease. And now the important point is that we want to discriminate them from any disease. Any disease that can be there, even those that haven't been invented yet. Now, in general, people have been working with that, so there are various ways to do it. We can either learn some sort of latent model and try to discriminate on a dimensionality reduced version of our image, if this is normal or not. A very common approach, which is the state of the art in medicine right now, is to just derive a biometric, a single number for your image, a measurement or whatever, and then put it in a percentile chart to compare it with an entire population to say if somebody is normal or abnormal. Recently, generative adversarial models have been used in this context, or autoencoders, where the idea is if I train a deep machine learning model to reconstruct only healthy data, then if I put in an image with disease, then what would come out is an image where the disease has been reconstructed away, right? Because the model can't know how this disease looks like in the reconstruction. Now, if you build the difference with the original sample, what you should get is a highlighted map of where your disease should be in the image. And we have recently pioneered an approach that is more straightforward, where we thought, okay, let's try to find the anomaly map and an anomaly score for each image directly, and we did this as self-supervised learning. And the idea is relatively simple. We take the training set as it is and mix it, right? So we take an area, like a square patch, in this case an area from one image, and put it into another image. So that is very subtle. That's very hard to distinguish and to see this abnormality. All right, in this case, we just do a simple blending of the training data, but what it gives us is an exact location where we have made this manipulation. So this is something we can train, we can show a deep learning model and ask. And with this blending, the result is an augmentation method, basically, and self-supervision method that leads to hardly identifiable changes, something at least for a human would be very hard to identify, and I have to admit I sometimes have a hard time to see those. So if I switch on to the next image, you'll see there's a slight change in the images, but overall you wouldn't be able, without the temporal transition, to see where the change takes place. Now we can choose any network to train such sort of self-supervision anomalies and build a representation of how normal looks like. In this case, we took a wide residual encoder-decoder structure, and we have an example here with a foreign patch, which is identified by a network. With the factor, with something like an interpolation factor here, we can also abuse this as a sort of abnormality score, how much abnormality is in this image. Now, this approach won a public competition last year, probably the only public competition in this space where it is about anomaly detection in medical image analysis. We have continued on approaches like this. In the meantime, we are pretty confident to identify, with certain constraints, a lot of anomalies in real medical images. So this is my conclusion slide. If you're bored of such slides, then probably try to find the anomaly in the image on the left. But really, I believe that these sort of methods really start to enable primary care health screening applications. We are probably able to provide means for quality control and a second pair of eyes for usually overstretched healthcare personnel and a surgery level like radiologists and people who have to report way too many reports every day and might miss something. So this has not been possible without my team, which is here, and funders and universities.